how would you explain CAR T therapy to a friend or family member who maybe is not so familiar with what that is?
It's basically a form of immunotherapy for cancer. So we all have these immune cells called T cells, which are really great at killing anything that is foreign in our body, like viruses, infections, and cancer. But the problem with these T cells is you can put them right next to a bad cell, like a cancer cell, and they wouldn't know what to do. Then we can send those T cells off to a lab, and what that involves is genetically modifying those cells.
It might be difficult for patients to find a provider who can offer these therapies.
Roughly 2 out of 3 patients who potentially could get this therapy end up getting it.
When is the right time for them to ask their community-based physician, right, if CAR T is appropriate for them?
As patients start this journey, if they have a cancer diagnosis, ask about these therapies early.
What's the single most important next step that you'd encourage them to take?
Knowledge is power, and advocate for yourself and your loved one. We can offer these therapies to patients who in the past, to be honest, we had no options for. Just know a lot of hope and a lot of optimism as we think about where cancer care is going.
Dr. Majhail, it's good to see you. Welcome to the show today. How are things in beautiful Nashville?
A little colder than what would be expected this time of the year, Chris, and so nice to see you as well.
Yeah, no, I really was so excited to have you on the show. I know we met back at ASH last December, the American Society of Hematology meeting, and we were so mission aligned, in our different disciplines around how we're trying to expand patient access to personalized therapies like CAR T cell therapy. So maybe to get started, I'd love to give you the opportunity to kind of describe a little bit your role, what you do, and how you've devoted your career to transplants and CAR T in general.
Yeah, sure, Chris. Happy to kick it off at letting your audience know a bit more about myself. So I'm the physician in chief of blood cancers at the Sarah Cannon Cancer Network, which is the cancer service line for HCA Healthcare. So in this role, I support the Sarah Cannon Transplant and Cellular Therapy Network, which currently consists of 10 complex blood cancer programs that will care for roughly more than 1,200 acute leukemia patients. And in addition to that, more than 1,600 patients who will receive CAR T cell therapies, gene therapies, and bone marrow transplants across the HCA healthcare ecosystem this year. So a huge network of sites and centers that provide high quality care. I'm also a practicing hematologist. And what that means is I care for patients with leukemia, and I care for patients who are undergoing CAR T cell therapies, as well as patients undergoing blood and marrow transplants. So that's my background in brief as to what I do.
And before we get any deeper into it, I know that many listeners may have heard the term CAR T, but maybe they're not sure what it is. So how would you explain CAR T therapy to a friend or family member who maybe is not so familiar with what that is?
Great question, Chris. And this is how typically I'll explain CAR Ts to patients who are hearing about this for the first time, right? So CAR Ts it's basically a form of immunotherapy for cancer. And again, with a caveat that we use it mostly for cancer today, but it's being investigated for a lot of other indications outside cancer as well. So we all have these immune cells called T lymphocytes or T cells, which are really great at killing anything that is foreign in our body, like viruses, infections, and cancer. But the problem with these T cells is you can put them right next to a bad cell, like a cancer cell, and they wouldn't know what to do. Okay, because they don't have a mechanism to directly recognize and identify that cancer cells. And what the human body does is typically it will help those T cells find the cancer cells through some other mechanisms. And once that T cells gets to see that cancer cell, it says, oh, okay, this is bad. I'm going to kill it. I'm going to destroy it through my own mechanisms that are inherent to me. Now with a CAR T, what we do is we take these T cells out of the body. So we have a procedure called apheresis where a patient's blood goes in, and that machine in very simple terms has magnets that pulls out those T cells. Then we can send those T cells off to a lab for manufacturing. And what that involves is genetically modifying those cells so that those T cells can start recognize those cancer cells directly. They don't need anybody's help. And we expand them, we grow them, we culture them, and then we give chemo to suppress the patient's immune system. And then we infuse these CAR T cells back to the patient. And they come in supercharged with a homing device in very simple terms that is targeted towards that specific cancer. And they go and find that cancer, attack it, and we cure many of these patients who in the past had pretty advanced life-threatening diseases.
So you had mentioned that the CAR T cell therapies were first approved in many different types of blood cancers, right? So can you maybe share a little bit about, we've heard data, maybe you could share some of the data around why access is so difficult for patients, right? Because many patients are seen out in community settings. Can you tell us a little bit about the settings of care and why it might be difficult for patients to find a provider who can offer these therapies?
Yeah, so these therapies are cell therapies at the end of the day, and they are complex therapies. There's a lot of care coordination involved. There's a lot of technology involved. So out the gate, over the last decade or so, since they were first approved, they've tended to gravitate towards larger, high-functioning, big programs that had the know-how and the infrastructure, either because they had participated in clinical trials for these CAR Ts, or because they had existing bone marrow transplant programs, because there are a lot of similarities between CAR Ts and bone marrow transplants. So that is where they gravitated initially, and that is where these authorized treatment centers were present. For the most part, now over the last decade or so, as these therapies have become simpler in the sense we know who the right patients are, we are better at selecting the patients to receive these therapies. The preventive therapies for mitigating side effects have gotten better. And also, last but not the least, we've gotten better at supportive care, supporting these patients through this process and journey. We certainly have the ability now to get them out to other sites which traditionally have not done these at all. And I think that's what the opportunity for these CAR T cell therapies are, because Chris, you talked about access, and based on the data that we have today for the existing indications, which are mostly blood cancer, roughly 2 out of 3 patients who potentially could get this therapy end up getting it, right? So this is some research we have done as well, others have done as well. I mean, there's a huge drop off with respect to patients who can potentially get these therapies and benefit from them. And again, several reasons for this. Some of this is disease related, but there are all these other access issues around geography,
Mhm.
payments, I mean, payers, insurance, other healthcare disparity issues that we're all very aware of that cut down the chances of someone who can benefit getting these therapies.
Is that 2 out of 3 statistic that you gave, is that the sort of CAR T rate for those who have already entered your system?
No, so this is patients, this is the totality of all patients who could benefit
Okay.
from these therapies. So if there's a lymphoma or a myeloma patient out there who could potentially benefit from these therapy, there are roughly 2 to 3 out of 10 who will get to it. Now, we have a network of multiple sites. Like I said, we have 10 centers that do it, including 7 centers that offer CAR T therapies. We've done this research ourselves, and we've seen that patients who hit one of our programs, so they've overcome that first hurdle of getting to a treatment
Hmm.
center.
Hmm.
So once they hit one of our programs, around 40% do not end up getting an infusion.
Hmm.
Okay.
Oh,
And
okay.
that again is delays because of insurance, their disease progressing, other complications coming up, or them not being considered eligible for something else.
Okay. We're going to get to that that intake process and how to find a treatment center in a moment, but I wonder for those patients out there or caregivers possibly who have a blood cancer or maybe they've already tried standard treatments. I mean, when is the right time for them to ask their community-based physician, right, if CAR T is appropriate for them?
So what I would say, Chris, is as patients start this journey, if they have a cancer diagnosis, ask about these therapies early, right? I mean, I'm going to take us up a notch, right, and get a bit broader than CAR T therapies as you think about cancer in general, right? So when patients get diagnosed with cancer, cancer is a complicated disease, and it's so much happening in this space, right? Things are changing pretty much every day in terms of the research coming out. And often it's hard for one physician to stay ahead of everything. Maybe with AI in the next few years, it'll be less of an issue, but at least as of today, it's hard to keep up with everything. And it's not unusual for patients to be able to have options, for treatment, which might be available at other centers versus where they're getting treated, right? So So again, so what I'm getting at basically, Chris, is if you think about CAR T, there are FDA-approved indications currently, where we know the FDA has said it's okay to use them from a commercial standpoint for lymphomas, myelomas, acute lymphoblastic leukemias, and so forth. But then there's all this research happening in the cancer space. Just coming back to CAR T as an example, where there are clinical trials happening, where things may be getting tested more early on in the disease process, or in a unique way where the existing CAR Ts may not be used currently, right? So what I'm getting at is if you have a cancer diagnosis, as you start this journey, do ask about treatment options that may be clinical trials, which are new and novel and innovative, so that your physician can work with you to give you a better sense of what your options are. At the end of the day, your physician knows you best. I mean, he or she can discuss with you as to what makes sense to you given your situation, but it's just nice to have all the options on the table.
Navneet, you mentioned that, when these products were first approved, they were mainly patients were treated mainly, within sort of large, like high volume academic centers or, authorized treatment centers. How do you see how do you see that evolving? I know you're behind a massive movement to try and bring this closer to home, closer to where patients live to help improve access. Can you tell us a little bit about that?
Yeah, Chris, I always say at Sierra Canyon, we are in the business of solving access to cell therapies, right? That's our mission and vision at a certain level, if you will. Now, just to give you some numbers, and you know this, right? Almost 70 to 80% of the patients who get a diagnosis of cancer, they get their care in the community, right? And we talked about the numbers where 2 to 3 out of 10 patients who need a CAR T therapy and could benefit from it cannot get it. And it's all those access issues around getting to a treatment center, right? So many of these patients, they live in these, what I call cell therapy deserts, right? I mean, the nearest treatment center is hundreds of miles away. And we've seen this story, for example, in Nevada. So we started a program at one of our HCA hospitals in Las Vegas. And prior to us starting that program in Las Vegas, many of those patients had to travel to California, to Arizona, or to Utah to get this care. And as you can imagine, if you have to travel that distance, many patients will not get that treatment. I mean, either the physicians won't recommend it because they recognize that patient doesn't have the resources or the support to travel, or the patient might be too sick to travel, right? And there are many patients who don't get this care, which is right for them. So since we've started the only program in the state of Nevada, we've seen some of these issues get mitigated, right? So again, I think that is where it is so important to think about this from a care delivery standpoint, where we can get this care more closer to home into the community. And a big part of this is trying to get this out there in many of the community practices across the country, which we know have the capabilities and have the infrastructure to provide these therapies to patients where they are.
So, what infrastructure is required for those sort of community practices to be able to do more of that care closer to where patients live? And like, how do you see that evolving in the next few years?
Yeah, so I think a couple of things you got to keep in mind. And again, it's not that all practices can do it, but again, we work with many of the community practices with this large practice groups like US Oncology Network or One Oncology or AON and so forth. And I mean, there are many of these groups which are large enough and they have physicians who focus on blood cancer care in specific, right? And as they've been working on this, and there are many of them who've successfully already done this in the community, right? So they have programs that are offering CAR T across their practice sites. And I think a couple of things that have innovated and are in the process of getting innovated as well. And as you think about the delivery of CAR T, one is the infrastructure around manufacturing and collection of these cells, right? So in the past, historically, CAR T cells have been given in what I call full service program. It's a one-stop shop. Everything is under one roof, right? But now there are companies out there which can contract out apheresis services or cell processing services and so forth, which obviously helps some of these community sites not need to invest in the infrastructure for some of those services because there are others who know how to do it, are good at it, and can help you with it. I think the other piece is having that local infrastructure like the right it's a team effort. I mean, it takes the village to do this stuff, right? The nurses, the social workers, the physicians, the APPs, the pharmacists. How do you build and train that core group that can help you provide this care? Then you will always need a hospital partner, right? You will always need a hospital
Okay.
partner, even though these therapies are getting safer and better. The rate and incidence of complications, especially severe complications, has gone down. There are still patients who will get bad complications like what we call CRS, cytokine release syndrome, or neurological toxicities who will need hospital-based care. How do you find a good hospital partner that can work with you to have the right triage pathways and other ways to make sure if someone needs this high equity care, they can get those patients in quickly. The nurses are trained. The hospital has all the medications to treat those complications and whatnot. And as you think about this ecosystem, how do you pay for this as well? Right? It's easy for payers to pay for all of this. If it's a one-stop shop, right? I mean, you go and you're just dealing with one entity, but now you're dealing with a separate entity that does apheresis, separate entity that does cell processing.
Hmm.
You're providing care in one practice, but you might be, I mean, the nice thing is you've got other hubs in that area that can help the patient get back close to home sooner. But then how do you pay for that piece? And then if a patient needs hospital care, how do you pay the hospital as well? Right. So there's this overarching ecosystem of how do you pay for this using the payment models we have today. And then last but not the least, how do you ensure the care that's provided is high quality, right?
Hmm.
At some level, we're fragmenting care more by getting more entities involved versus a one-stop shop approach to providing care. But then how do you make sure that the care that's provided is high quality as well? And that's where, in my opinion, things like organizations like FACT come in that can certainly come in and ensure all the parts and pieces to providing good care are present.
So if someone's listening and they want to know if there's a specialist at a CAR T center near them, what are the one or two concrete steps that you would suggest they take?
So currently, most of these CAR Ts are available for cancer diagnosis, mostly blood cancers, along with clinical trials in solid tumors and so forth. So usually, your oncologist you're working with most likely has a connection with someone who focuses on this therapy. So your treating physician is a good first step to ask about whether or not there is a CAR T center that you need to be referred to. And I think with all the education out there, the majority of our physicians now have a good sense of who has an indication for CAR T or not, right? So certainly they can work with you to make that determination. And then second, I mean, we've got all these resources on the internet as well. I mean, I think everyone likes to go to Google, for example, to get some
Yeah.
information. I mean, and again, there are certainly patient advocacy organizations like Blood Cancer United and many others out there, which would be a good resource to identify what might be a close by center to you. Again, all of these CAR T companies have their own websites that list treatment centers and whatnot. But again, there are many of these resources that can help you get navigated to the right place.
And I know we're talking a bit about sort of CAR T cell therapy being administered in an inpatient versus an outpatient setting. I don't know if many of our listeners are probably as familiar with the nuances of what that means. Could you maybe
Right.
please explain that difference and the benefits of being able to have care closer to home and sort of an outpatient setting close to where they live?
Yeah, I'll begin by saying patients recover better if they're not in the hospital, Chris, right?
Mhm.
So that is always ideal.
Mhm.
But now, as you think about these CAR T therapies, if you look at the legacy days when they were early on, the majority of care was provided in the hospital. So patients would stay in the hospital for 2 to 3 weeks. And the chemo, the cell infusion, and the monitoring after that was all in the hospital. And the reason for that was it was new therapy. And early on, we recognized and realized that patients can get some very unique side effects. There's one called cytokine release syndrome, where the immune system gets revved up and causes complications. And then there are neurological complications, what we call ICANS, immune effector cell associated neurotoxicity syndrome. And that's where people can get uptended, confused, even get seizures. And these complications we learned early on can happen pretty quickly and can get severe pretty quickly. So that was a genesis of why patients were kept in the hospital for 2 to 3 weeks as these therapies were initially being discovered and developed. Now, over the years, we've gotten better at selecting patients. We've gotten better at preventing these complications, and gotten better at treating these complications, right? And that is where there is an increasing push to get these therapies out into the clinic setting, so where patients don't have to be admitted as much. Now, having said that, these are still resource-intensive therapies, right? You need a whole team taking care of you. And at Sarah Cannon, we've developed some unique models to facilitate this care in the outpatient setting. We use remote patient monitoring where patients are available, and we can monitor them through a centralized command center. And I know there are other centers doing other innovative things in this area as well, where they're testing out and innovating and trying to think about other ways and models to keep patients more in the outpatient setting and only admit them if it's needed. And this is relevant as you think about the community practice care, right? Because these are community practices. And like I said, the beauty is if patients can stay home, they don't have to be in the hospital. I mean, you know this. I mean, patients eat better, they do more, they're more active, they get more support, from their family and so forth if they are at home. And certainly, I think that's a huge advantage as some of these practices are looking at these outpatient care models as well for these CAR T therapies.
I know we both attended a sort of a hospital system CAR T cell therapy conference earlier this year, and I know one of the big themes was the importance of the caregiver. Can you maybe describe, maybe for those who are listening, like why is it so critical to have a caregiver support throughout this journey?
Yeah, caregivers are so important in this process for patients because, I mean, the idea is hopefully patients do okay without getting too many severe complications as a part of this process. But we know patients can get pretty sick, where they can sometimes need help with medications, mobility, other routine tasks that they may be doing. I mean, making sure they're getting their medications at time. And I talked about some of these side effects, which can certainly impede people's ability to drive and be very functional all the time. So that is why caregiving piece is so important. And a routine part of this process is certainly assessing and educating patients about the need for a caregiver and helping them find the right caregiver, and also educating those caregivers about what to see and what to expect.
So you mentioned that these therapies were first approved in oncology indications and blood cancers. They're being explored in other types of cancers, and I know there's other investigation going on in other indications. Can you maybe share with us, like, where do you think in the next 2 to 3 years, let's say, how do you see the field evolving, different indications, like, where's the reason for hope and optimism here? How do you see the field evolving so that patients can benefit from these truly personalized therapies?
Yeah, so a lot of stuff happening, Chris. And I always tell our trainees who work under me and our programs that we're doing science fiction medicine in cancers nowadays, right? So if you think about these CAR T cell therapies, they're called chimeric antigen receptor T cell therapies because, I mean, chimeric basically is a cell that I think it comes from Greek or Latin. I'm not sure, but basically it means it's a mix of different organisms. And essentially, we are making these cells that don't exist in nature, right? So that is how interesting and innovative all of this is. Now, I talked about those CAR T cells basically having a receptor or a homing device in very simple terms that can identify any cancer target. Now, as you can imagine, you can genetically modify those T cells to basically generate or make a receptor for any target, right? So that is where these are being investigated for solid tumors as well. So many of the solid cancers are undergoing clinical trials with a whole variety of CAR T cell therapies that are targeting some of the antigens or these targets, which are very specific to those cancers. And then it's going into autoimmune diseases, into HIV, into a whole spectrum of other diseases which are immune mediated.
Wondering, just as we get close to wrapping up the show, what are your thoughts on the in vivo CAR T, right? I mean, we were talking mostly about now CAR T where patients' own cells are harvested through apheresis and then manufactured and given back, but fixing or targeting disease within the patient's body. Where do you see, how do you see that evolving over the next few years? How close are we to realizing that?
So I think we're getting pretty close. And again, for your audience, we talked about, taking the cells out and then manufacturing them in a lab. I mean, here you're injecting the manufacturing cells into the body, right? So it's just happening inside your body as these CAR T cells are being manufactured. And there have been some early reports in a variety of blood diseases, autoimmune diseases, where these in vivo CAR Ts have been shown to be effective. Again, very early in the space right now, but I think in the next many years, we'll see more trials and more data come out. So I'm very optimistic and very bullish that these in vivo CAR Ts ultimately will come out in a big way, and certainly looking forward to that innovation.
And just to close the show, I'm wondering if someone's listening right now, maybe a patient or a caregiver, maybe, who thinks that CAR T might be relevant for them or a loved one, what's the single most important next step that you'd encourage them to take after listening to this show?
I think a couple of things to keep in mind. One, knowledge is power, and advocate for yourself and your loved one. I mean, there are many resources out there about cancer treatment and so forth. So do explore them, right? And hopefully you can find a treatment team, not just a physician, but a treatment team that you can trust and advocates for you. And be strong. I mean, I'm very hopeful for where things are going. I mean, we're talking about CAR Ts. They've just come out in the last 15 years or so. And now we can offer these therapies to patients who, in the past, to be honest, we had no options for, right? So sometimes science doesn't move fast enough to treat you or help you today. But just know a lot of hope and a lot of optimism as we think about where cancer care is going.
Well, Navneet, I want to thank you for being on the show. You're a true legend in the industry, and you're so passionate about making sure that every patient who could potentially benefit from CAR T cell therapy, that they have an opportunity to access it. Thanks for all the great work you're doing, and thanks for taking the time to join the show.
It's been a pleasure, Chris. Thank you.
If you enjoyed this conversation, be sure to subscribe to the RX for Biotech podcast to hear directly from the leaders who are shaping the future of personalized medicines. And if you or someone you know is navigating a care journey, be sure to visit therapyforme.ai to search for a specialist near you. And if you need that extra support, be sure to schedule a virtual telehealth appointment with one of our nurse navigators who can help answer your questions. Thank you for listening.